Acral lentiginous melanoma. Definition: Acral lentiginous melanoma is a kind of lentiginous skin melanoma. Melanoma is a serious skin cancer that arises from pigment cells, melanocytes. Although acral lentiginous melanoma is rare in people with lighter skin types, it is the most common subtype in people with darker skins. Acral lentiginous melanoma is observed on the palm, soles, under the nails, and in the oral mucosa. It occurs on non-hair-bearing surface of the body, which may or may not be exposed to sunlight. It is also found on mucous membranes. It is the most common form of melanoma diagnosed amongst Asian and Sub-Saharan African ethnic groups. The average age at the diagnosis is between 60 and 70 years.
In this video, we're going to look at melanoma. This is an overview of melanoma, an introduction. Melanoma is cancer of the skin. Melanoma has the highest mortality rate of all dermatological cancers. Melanoma is also one of the most common cancers in young adults. So what are some risk factors for developing melanoma? Well, some common risk factors include having a family history of melanoma, having a personal history, having light hair color, light eye color, having a high freckle density, being immunosuppressed either because of the use of drugs or having a particular disease, and having multiple melanocytic nevi, essentially multiple moles. So how does melanoma look like? Well, melanoma looks different in each individual. So let's zoom into this person's face. And here's a cross-section of a skin with melanoma. Let us compare this to a normal skin cross-section. The top layer of our skin is known as the epidermis. Below the epidermis is a layer called the dermis. Below the dermis is another layer known as the hypodermis, which contains subcutaneous fat, which is important for thermoregulation. As I mentioned, melanoma is different in each individual. However, melanoma is usually always pigmented. It's a pigmented lesion, it's often asymmetric, it has ill-defined borders, and melanoma often bleeds or ulcerates. So how does melanoma develop? Well, let us zoom into the epidermal layer of the normal skin and compare it to the epidermal layer of a skin with melanoma. We are now looking at the pathology of melanoma. So here are some cells that make up the epidermis. Here again is our epidermal layer, and below the epidermis is our dermis. In between the epidermis and the dermis is our basement membrane. Essentially, this is what separates the epidermis to the dermis. Just above the basement membrane, we have a special cell of the skin known as melanocyte. Melanocytes are important for us because they help protect us from UV radiation, and they help in our skin pigmentation. In melanoma, what happens is we have proliferating melanocytes. So these melanocytes that are normally harmless become mutated, and they grow and divide rapidly, resulting in melanoma. These risk factors can lead to these proliferating melanocytes. When going to a doctor and is suspected of having melanoma, it is important to examine the skin lesion. A good way to examine the skin lesion is to follow the ABCDE rule. So in A, we look for asymmetry. In B, we look for ill-defined borders. In C, we look for any color changes or even bleeding. In D, we check for the diameter and possibly the depth. And E, possibly the most important, is we look at elevation and in particular evolution. So if the skin lesion changes quickly or rapidly in a short duration, melanoma is suspected. There are ways to prevent melanoma. These include wearing a hat, using sunscreen, wearing long-sleeved shirts, protective clothing, especially if you work outside a lot, wearing sunglasses, and also, if you have a family or personal history of melanoma, having regular doctor skin checks or even self-skin checks. So that was an overview of melanoma. Thank you for watching.
Applications in medicine. If you get diagnosed early and seek treatment to stop acral lentiginous melanoma from growing and spreading, the outlook for acral lentiginous melanoma can be good. Early stage. If your acral lentiginous melanoma is still in the early stage and is small enough, your doctor may simply be able to cut the spot of acral lentiginous melanoma out from your skin in a quick outpatient surgical procedure. Your doctor will also cut out some skin around the area. How much skin needs to be removed depends on the Breslow thickness of the melanoma, which measures how deeply the melanoma invades. This is determined microscopically. Melanoma in situ. The excision margins 5 millimeters. Melanoma less than 1.0 millimeters. Excision margin 1 centimeters. Melanoma 1.0 to 2.0 millimeters. Excision margin 1 to 2 centimeters. Melanoma 2.0 to 4.4 millimeters. Excision margin 1 to 2 centimeters. Melanoma less than 4.0 millimeters. Excision margin 2 centimeters. Advantageous stage. Advanced stage. If your acral lentiginous melanoma has a deeper level of invasion, lymph nodes may need to be removed. Amputation of digits may be necessary if there is evidence of distant spread, such as to other organs. You may need treatment with immunotherapy with biologic medication targets receptors in the tumor.
Acral lentiginous melanoma. Acral lentiginous melanoma accounts for 7% of all melanomas. Acral lentiginous melanoma is more common in males than females and usually in older people. It occurs primarily on the hands and feet, including the skin surrounding the nails of people with darker skin types 4 through 6. Similar lesions also occur on the modified skin around the mouth, anus, and genitalia. Acral lentiginous melanoma is the most common form of melanoma in the skin of Asian and Black people, accounting for more than half of melanomas in these groups. It is the least common form of melanoma in Caucasian people. Other than location, the lesion is similar in appearance to lentigo maligna and lentigo maligna melanoma, appearing as a flat, slowly expanding pigmented macule with a fairly uniform mottled color. It appears and evolves over years. The sudden appearance of a pigmented band originating at the proximal nail fold or pigmentation in the proximal or distal nail fold is called Hutchinson's sign and is suggestive of acral lentiginous melanoma.
Advantage and disadvantage. Advantage: if caught early, acral lentiginous melanoma has a similar cure rate as the other types of superficial spreading melanoma. The vessel thickness is reported for invasive melanomas. It is measured vertical in millimeters from the top of the glandular layer to the deepest point of tumor involvement. It is a strong predictor of outcome. The thicker the melanoma, the more likely it is to metastasize, spread. If you get diagnosed early and seek treatment to stop acral lentiginous melanoma from growing and spreading, the outlook for acral lentiginous melanoma can be good. Disadvantage: it has been demonstrated that acral lentiginous melanoma has a poorer prognosis compared to that of cutaneous malignant melanoma. The pathogenesis of acral lentiginous melanoma remains unknown at this time. Acral lentiginous melanoma may be hard to recognize at first when the patch of darkened skin is small and looks like little more than a stain or bruise. Early diagnosis and treatment are essential. If the melanoma is widespread, other forms of treatment may be necessary, but are not always successful in eradicating the cancer.
The doctor is in. Hi guys, it's Dr. Sal from DrSecrets.com. Thank you so much for joining in. Today we're going to take a look at melanoma cancer. This is the most scary skin cancer that someone can get. Compared to all the other skin cancers, they're like minor villains or minor players on this play. Melanoma is approximately 10 times more likely to spread and disseminate than all the other types of skin cancer. The other thing is it's also very capricious and unpredictable. Most of the other types of skin cancers that I've seen, which I will detail in another video, I usually expect to see them in areas which are sun-exposed dominant or occupationally sun-exposed dominant. Melanoma, on the other hand, very unpredictable. I've seen it on people's feet, even in people's eyeballs. Is very unpredictable. The other problem with it is it's like an octopus. It tends to burrow and it has tentacles that tend to spread out quickly. If you look at this slide here of this unfortunate gentleman, this is an example of what melanoma does. It tends to be like a crazy octopus that spreads under, or like the tip of an iceberg where you just see something on top, but underneath it's burrowing down and spreading out. It's a nasty ailment. So how can you spot it? To avoid it? Well, take a look at this slide over here. What this is showing is that many spots that you think might be melanomas probably are not. This column on the right, these are all benign lesions. This column on the left, these are all melanomas. Now, the key to remember is that not every dark spot on your body is a melanoma, but every melanoma is dark. That asymmetry is part of what makes it difficult for you as an individual to determine whether you have a melanoma or not. But we do have a tool for you that you can use to help you gauge whether this is something you need to see a doctor about or whether it's something benign. And it goes by an acronym of A, B, C, D, E. A is for asymmetry, B for border, C for color, D for diameter, and E for evolution. So what does all that mean? Well, asymmetry, if you put a line down the center of this lesion here or down the center of this one, or put a mirror, better yet, if you put a mirror down the center of one of these lesions, what you will see is the mirror image looks just like the entire composite when you're done. If you try to do that with this one, or this one, you will see that the two halves of the mirror image do not match. That is asymmetry, and that's one of the key features with these nasty melanomas. The other thing is the border. Now again, look at the border, the area or circumference of these lesions here that are benign. In each case, it's a perfect round, almost planetary looking phenomenon. When you try to trace that around with a pencil with these guys here, you can see it's not a nice, smooth, regular edge. It's very rough and irregular, bumpy, lumpy consistency. I hope you can appreciate that here. The other thing that we look at is color. If you look at these benign guys here, the color is almost uniform. I can take if I use a digital imaging sampling technique, you'll find that wherever you sample pretty much matches wherever else you sample. That is not the case with these melanomas here. If you look here, it's very dark here, kind of light brown here, dark here, brown here, almost like pizza in this one. And again, there's this loss of continuity of color. The next thing we look at is diameter. How big is it? All these guys here are small. And typically we say that if you see a lesion on your skin that is more than 6 millimeters in diameter, then you probably should come see us so we can take a look at it for ourselves. Now, it just so happens that 6 millimeters is roughly the diameter of a pencil eraser. So that is 6 millimeters right there. So if you see something on your skin bigger than that rubber, you probably should come and let's take a look at it. The other thing is evolution. And evolution just means that you're looking at this thing, and every couple of months you notice, geez, this thing looks like it's getting bigger and uglier every day. Again, if you notice that, you should come see us. Because these other benign lesions, they usually stay pretty much looking the same for a year at a time, or maybe even a couple of years. They're usually fairly static, or they grow very, very slowly or indolent. These melanomas, they just love to grow. And that's part of what makes them so dangerous, because once they start burrowing, they just spread out like wildfire. So that, ladies and gentlemen, is an important technique for you to learn to figure out whether you have could be developing melanoma or not. It could save your life or limb. And that's it in a nutshell. So thanks so much for watching. I hope this saves you some grief sometime in the future. Don't forget to subscribe so I can keep you up to date.
Issue applied in Ecuador. The universe of this research is constituted by 60 cases of melanoma malignant that belong to the cities of Quito, Guayaquil, and Cuenca. The information is found in the database of the National Registry of Tumors in the period from January 2000 to December 2008, whose headquarters are located in the Hospital of the Society of Fight Against Cancer in the cities mentioned above. The data was collected directly from the computer system. Annual melanoma incidence rates. In this table we can see the median annual melanin incidence of melanoma in the entire sample was from 2.9 with a minimum range of 0.2 and a maximum of 7.5 cases per 100,000 population. In Quito, the median incidence rate was 3.1, 2.5 to 4.4 cases per year per 100,000 inhabitants. In Guayaquil, we found a median of 0.6, 0.2, 0 to 0.9 cases per year per 100,000 inhabitants, and in Cuenca the median was 4.6, 2.7 to 7.5 cases per year per each 100,000 inhabitants. In the second table, we can see the age. The median age of the entire sample was 63 years with range between 0 and 103 years. In Quito, Guayaquil, and Cuenca, the median age was 63, 0 to 103, 62, 22, 98, to 98, and 64, 1 to 98 years respectively.
new videos as I upload them.
Welcome surgical oncologist who specializes in melanoma, Dr. Travis Kidner, to the show. You addressed it early,
right?
And you have had treatment?
I have. I actually called my old boss who trained me how to operate on melanoma patients. And I said, I have another patient for you. Unfortunately, it's me. And so the treatment for this is they have to excise a wide range of skin around the tumor, but then also sample the lymph nodes. The problem that makes melanoma so dangerous is that it can travel through your lymph nodes and different spots in your body.
And in your case, it did come out. Tell us about what they found.
The nodes were negative, so it's a stage 1 cancer, very high survival. I'm going to be okay.
And that's the moral of the story here is keep track of your moles, regular checkup. We have some frames up here. Let's go through these because, Dr. Travis, I want you to turn back to being a doctor because you went through this as a patient. The fact that you caught it early is why things have gone well for you. If you wait too long, that's when malignant melanoma becomes particularly deadly. So let's walk through some moles versus melanoma.
So one place people tend to forget to look is on the bottom of their foot. Either for mobility reasons, they forget to look, and these are caught at a much later stage. This one has an irregular border. This is malignant melanoma.
And just the color. We know, we've seen it. You can get that in the nails, you can get it in the back of the eyes, so that's a great point. There's certain parts of the body that are easy to miss.
Very concerning. This needed to be checked out months and months and months ago. It can also happen, like you said, under the toenails, so look there as well. So, concerning mole or melanoma?
So we see this a lot. I have people come in very concerned about these, but you can see it's a pretty uniform color, and the border is very smooth. This is actually a benign lesion.
All right, and again, sometimes to the untrained eye, what looks scary may be very benign. But that's why if there's a concern, biopsy is done, it's looked at under the microscope. This is one of those lesions a lot of people look at and say, well, benign or malignant?
So these are the kind that I'll be sent in by, my hairdresser saw something. They said I should get this checked out. And you can see the borders are regular, and there's 2 different colors, multiple colors and a regular border. This is actually a pretty bad melanoma.
So the borders, the color, this is very concerning. You would always biopsy that.
Like in your case, if it's changing rapidly, if it's evolving.
Now, this is one that we see a lot. It's a raised lesion, and a lot of people have these. Mole or malignant?
So this one again, you kind of look at the border. The border is pretty smooth, and it's smooth as well. And if this was staying the same over years, this would most likely be benign, which this one was.
And based on the color too, even though the lesion that you had was similar color to this. So, if there's any question, you need to investigate.
And you have to look past the ABCDEs as well. If something starts to ulcerate, starts to bleed, starts to itch, if your wife or your husband says you should get that checked out, those are all good indications to go get it checked out.
Better safe than sorry. Dr. Travis, we are so glad that you had, and I like saying it. I love having Dr. Travis.
Dr. Travis.
So glad you had a good.
And finally, the conclusion. My conclusion is that acral lentiginous melanoma is the most common type of melanoma in people with darker skin and those of Asian descent. However, it can be seen in all skin types. Acral lentiginous melanoma may be hard to recognize at first when the patch of darkened skin is small and looks like little more than a stain or bruise. Early diagnosis and treatment are essential. Acral lentiginous melanoma becomes invasive when the melanoma cells cross the basement membrane of the epidermis and malignant cells enter the dermis. Rapidly growing nodular melanoma can also arise within acral lentiginous melanoma and proliferate more deeply within the skin.
Abnormal growth. Skin cancer, like cancer in other organs of the body, is the result of the uncontrolled abnormal growth of cells. The transformation of normal skin cells into skin cancer has a variety of causes, the most common being sun exposure, family history, and ethnicity. When the cells of the skin begin to grow in an uncontrolled abnormal fashion, a tumor will result. This tumor is malignant. A malignant tumor is considered a cancer and should be removed to prevent the possible invasion and destruction of surrounding normal tissue or spread of the cancer to other organs of the body. This is known as metastasis. Fortunately, metastasis of skin cancer is not common. Basal cell carcinoma, BCC, is the most common type of skin cancer in the United States. Approximately 1 million cases of BCC occur annually. About 80% of all skin cancer cases are BCC, the slowest growing and least dangerous of the 3 common types of skin cancer, and it rarely metastasizes. BCC develops from the cells in the epidermis, the surface layer of the skin known as the basal cell layer. Basal cell carcinoma may have many different appearances. It most commonly appears as a small pearly skin-colored bump or nodule. Basal cell carcinoma can also appear as a flat growth, a scar, or scaling area. Untreated, basal cell carcinomas may begin to bleed, crust over, and spread into surrounding tissue, leading to more extensive surgery and scarring. Squamous cell carcinoma, SCC, is the second most common type of skin cancer in the United States. Approximately 200,000 cases occur annually. SCC is responsible for about 16% of all skin cancer cases. This cancer develops from cells in the epidermis known as squamous cells. Squamous cell carcinomas are more dangerous than BCC because they have a greater tendency to recur after surgery and to metastasize to other organs in the body. It often appears as a red nodule or rough scaling patch. Malignant melanoma, MM, is a life-threatening skin cancer that develops from the pigment-forming cells in the skin. It often presents as a black or brown mole. It can also include other irregular colors such as red, white, blue, and gray. Malignant melanoma is the least common of the 3 types of skin cancers, but it is the most dangerous because it has a strong tendency to metastasize to distant organs. Start as small bumps on the skin that slowly or sometimes rapidly enlarge. These bumps are usually pain-free and may have been present for a period greater than 2 weeks. Skin cancers frequently undergo periods of ulceration and bleeding followed by healing, then a repeat of this cycle. Your dermatologist should examine any skin lesion that has a history of bleeding. Skin cancers may have a variety of appearances. They may be flesh-colored, waxy or pearly, red scaly patches, large tumor masses, or sores that do not heal. A biopsy may be required to determine if the skin lesion is in fact a skin cancer. Skin cancers frequently invade surrounding normal tissue, causing extensive destruction of skin and bodily structures. Many cancers may form roots or fingers of diseased tissue that can extend beyond the boundaries of the visible cancer. Cancers that are most likely to form these complicated root systems are located in cosmetically sensitive or functionally critical areas around the ears, eyes, nose, lips, and scalp. Located in areas where excess tissue is minimal, such as the fingers and genitals, or where circulation is poor. Cancers that grow rapidly and or uncontrollably, or are cancers that have been previously treated. Most micrographic surgery is the most precise method for skin cancer removal, with the highest cure rates. Most micrographic surgery is effective for most types of skin cancer. However, it is most commonly used to treat basal and squamous cell carcinomas. In recent years, we have seen an increase in skin cancer rates. One of the major risk factors that can be controlled is sun exposure. It is important to keep exposed skin out of direct sun and to use a good sunscreen on exposed skin when you are in open daylight for more than a few minutes. Damage to the skin is cumulative. The best prevention is to protect your skin from direct sunlight as much as possible. Sunburns are the leading cause of skin cancer. Tanning is the skin's defense response to the skin's damaging rays, ultraviolet light, but tanning does not prevent skin cancer. One severe sunburn can increase your risk of skin cancer by as much as 50%. Sun damage to the skin accumulates over many years of exposure, and about 90% of sun-induced skin cancer occurs in the areas that have the greatest exposure, namely the head, neck, and forearms.